Last segment, we were discussing the issues with how rapid things have changed over the last number of years in the management of cancers from the point of view, certainly of systemic therapies. And I'm going to, over the next few segments, really focus on my own area of clinical and research expertise over the last several decades, which has been the GYN cancers. So very briefly, and this can be done briefly, we asked the question 30, 40 years ago, how did we manage from systemic perspective the three major GYN cancers: ovarian cancer, endometrial cancer, and cervix cancer? Is pretty straightforward. Ovary cancer, obviously a prototype for drug development over many decades. We have the alkylating agents, and of course, the profound change came with the introduction of cisplatin. But then over 30 plus years, what we had was cisplatin, and then we had a safer, not better, but a safer alternative, easier to give, much better tolerated, carboplatin. And of course, carboplatin is the standard of care today, 30 plus years later. We had a second agent, which could have been doxorubicin, it could have been cyclophosphamide, and then we had paclitaxel. Again, we're talking about 30 years ago. Carboplatin, paclitaxel, 6 cycles, he stopped. Patient recurred within 6 to 12 months. You'd say they were platinum resistant and not give them a platinum. It was longer than 12 months. You'd give them a platinum again. It was debated what, should we use 6 months or 12 months? Well, that was it. There were questions about, IP therapy, which we'll come back to another segment. And then we used multiple single agents along the line. That was the therapy in the resistant setting. That was the therapy. That's really what you needed to know. Endometrial cancer was actually even easier, and one can say distressing at the time. We had essentially no trials. We would give hormonal therapy, progestational agents. If there was a low-grade cancer, or we actually looked for receptors, there was so little work in this area, we didn't even bother looking for receptors. Low-grade cancer, you would give potentially a hormonal agent. And if it wasn't low-grade, and most of them weren't in the metastatic setting, you'd give a variety of drugs, just like you gave in ovarian cancer. There was essentially no research in the area. So what it used, if you use an ovarian cancer, it used an endometrial cancer. The situation was so poor in terms of the research, what we knew. There was actually a period of time, which many people have forgotten, and I tried to forget. We were actually giving cisplatin, paclitaxel, and doxorubicin, the three together, with very little rationale because there was so little research being done. And finally, we turned to cervix cancer, where essentially we had and still have, from the cytotoxic perspective, one drug, and that was the platinum. We use platinum, using a higher dose, a little lower dose. We might give in combination, we might give it by itself. But then when the landmark studies were conducted that demonstrated that chemoradiation improved survival in cervix cancer, we then moved cisplatin up front, giving it weekly with radiation, which was an incredible advance. The issue then was we had no systemic therapy. We had no other drugs that worked in cervix cancer. So although we might give a variety of agents, we in fact had no therapy that we'd shown was of much benefit. That was the state of affairs until relatively recently. It was not good for patients, but it was easy to remember for doctors. One could relatively easily be trained in this. Cookbook was not that complicated, but because we had limited agents and limited positive trials that influenced our care. I'm going to come back to just how dramatically things have changed in these three illnesses and the impact of that on decision support and the requirement for decision support. Thank you for your attention.